Hi, thanks for inviting us today. We're here to talk about FAST-HIV, which is feasible, accessible, standardized testing for HIV in the emergency department. My name is Megan Landis, and I'm an emergency doctor at the University Health Network, an associate professor in the Division of Emergency Medicine at the University of Toronto. And with us today is also Alexandra McKnight, who is the program manager for this project and helps it all run. These are our disclosures. So what is FAST-HIV? So the purpose of the project is to create a streamlined solution for rapid HIV testing in our emergency department. The methods we started back in 2019, where we started with environmental scans, barriers and facilitators exercises in order to guide implementation. And then in early 2020, we started building our implementation team. And then something called COVID-19 happened. So there's been a bit of a delay, but we're very happy to say that we have launched testing in our emergency department as of this week and are working towards our process evaluation. So why do this project? Well, we know there's a large number of people living in Canada with HIV who don't know their status. And we also know that there's high-risk populations that frequent our emergency department. So in particular with the opioid crisis, persons who inject drugs, also with limited access to care throughout COVID, newcomers to Canada, and other people who have limited access. So the ED is actually an opportunity for HIV testing. However, it's not happening. And part of the problem in Ontario is that typically the MOH has not had a license for populations within the emergency department to provide hospital testing. We've had licenses for transplant patients, women who are imminently delivering, as well as occupational exposure, but the hospital hasn't been able to do that rapid test for anyone else in our emergency department. And across Ontario, we've learned that no EDs actually have any of the point of care testing programs through the AIDS Bureau and the Ministry of Health. What happens in our emergency department is that we offer a test and then we send it to the Public Health Ontario labs. The answer does not come back in real time. There's no clear follow-up from an emergency department provider. It's not information that helps us with our clinical care. And as a result, providers are not engaging in doing testing in the emergency departments. So we started with a literature review along with an environmental scan. And what we found is that there are a number of departments across Canada who've engaged in doing some form of HIV testing in the emergency department, but there's a lot more in the US. What we found that there was nearly an equal split in the programs between using an opt-in versus an opt-out approach. And what a lot of the programs, at least in the published literature, showed was that people were conducting seroprevalence and screening studies, which were mostly research funded, and many of them ended when the research funding ended. So what we were looking for was a way of actually integrating sustainably HIV testing into our emergency department. We also looked to speak with people across Canada who'd had experience with this. And what we found across the emergency departments in Canada was that consent practices varied greatly. There isn't really a standardized approach across Canada. The decision to actually test by an ED provider is hampered by the burden of who follows it up and who's responsible for it. Across the board, all rapid testing was done in a lab. If it was done at all, nobody was doing point of care at the bedside. And really, we learned that there were a lot of structural barriers that needed to be reduced across Canada and in our emergency departments to provide HIV testing.
So we also asked ED staff and lab staff about their perceived barriers to implementing FAST-HIV. A couple of the key ones we heard were concerns around increasing healthcare worker workload, so particularly around ED flow, whether the ordering process would be overly cumbersome. And we tried to address this through our opt-in approach, which we'll discuss in a few slides, as well as a concern around increased cost. So particularly if we were choosing to pursue a seroprevalence study, which again, we are not, and we'll discuss that in a few slides as well. There was a real concern that would cost a lot of money. And so we've moved away from that. And finally, the third kind of major barrier that we heard was just around some knowledge gaps. So why are we testing in the emerge? What's the benefit? And we've addressed those concerns through the onboarding sessions that we're running with providers. And then in terms of the facilitators that we heard, the major one was making sure that we are involving and consulting with all ED staff early on. So we did this through attending nursing huddles, through our onboarding sessions, through having various meetings with kind of everybody that we could, and doing this barriers and facilitators exercise in itself, as well as making sure that the processes that we were deciding on were aligned with processes that were already in place. So we're mapping on to things that staff are already familiar with, which we're hoping is going to make everything go a bit smoother.
So we've chosen to do a rapid test in our lab. It was very clear from providers that adding a point of care test at the bedside was not going to be a feasible option. So we're using an antigen antibody test that's being run by our core labs. It's going to be a venous blood draw. And at the same time as we send the test to the lab, they also send a sample to the Public Health Ontario labs for confirmatory testing. The test is ordered within our electronic patient record. And the result is available within about 3 to 4 hours, which is not, it's in line with how long often people stay in the emergency department anyways. And it's available for 24 hours a day, 7 days a week. So who we've decided to test, we're not doing a screening study. We've decided to do targeted testing. So currently ED providers can offer a patient test. And who we're offering the test to is patients who end up disclosing risk factors in their care. So we're not asking everyone who walks in a list of their risk factors if they have a broken ankle, but if it becomes obvious in care, we can offer a test. If patients coming in with a clinical condition that's potentially related to HIV and this information is useful in their clinical care, we can offer them a test. And we're also, if patients request a test, we will offer them a test. The process is we have developed pre and post-test scripts that are available on our intranet with our patient care partners. We've integrated the HIV testing as a screening test in the emergency department into our electronic medical record. The process has been organized and sorted in our core lab. And also we have a process for linkage to care, which maps onto other rapid follow-ups that we have. So if a patient is positive, they will be rapidly referred to our infectious disease clinic at the UHN, and they'll probably see them within 24 hours, at which time they can access social work as well as in the emergency department at the time of getting the information. And they can refer them on to patient partners. If they're negative, we have the opportunity to also send them to infectious disease if considering PrEP. And we've also provided some prevention counseling materials. So we've had a lot of challenges around licensing, and the issue has been that historically there's been no hospital license that encompasses ED patients. So we, for about 1.5 years, tried to circumvent this by getting a research license from the Ministry of Health in order to implement in our ED, at which point in time COVID hit and everything went dark, essentially at getting an answer about licensing. But the good news is that finally in 2021, after many discussions, we have finally received a special populations license. And essentially that's for testing individuals at high risk in a healthcare setting. And the also good news of this is that because we now have an official license and it's not a research project, the testing now gets absorbed into the core lab budget. So we don't have to come up with extra funding for doing the testing. What we've done so far is we've completed an initial training of super testers. So we're doing a soft launch still because things are challenging in the emergency department to start new things in the middle of a pandemic. So we've trained about 10 super testers. We launched on Monday in order to try and figure out what processes are working and what aren't. And then we're going to do a full launch probably in about a month by providing, there's about 100 emergency department providers that we have to train, but we'll probably hope to do that in about a month from now.
And along with our full launch, we'll be launching our process evaluation. So we're measuring both clinical and implementation outcomes. This is a snapshot of the clinical outcomes that we're interested in, and really primarily looking at the change in the number of tests that are ordered in the emergency department. Our pre-implementation number is quite low, and so we're anticipating that we're going to see an increase in the tests that are ordered, and that's what we're hoping for. And in terms of implementation outcomes, just looking at, was the rollout successful? We'll do a follow-up to the barriers and facilitators exercise that we did at the beginning, looking at ED stakeholder knowledge, feasibility of the testing, acceptability, and then we'll do some patient satisfaction short interviews as well by phone to make sure that, that it's well received by patients as well. And then, of course, we'll look at disseminating through both our kind of emerged communities as well as the HIV community.
So I think there's some interesting opportunities for scale up. We are hoping, we have a grant in currently in order to involve our Thunder Bay partners in doing this similar work. So I think there's an opportunity for multi-site involvement. And, you know, we get lots of questions around what else can we find out about what's happening in the emergency department. And I think there's an opportunity once we get the test up and running for further epidemiological studies. So looking at who's accepting a test, who's actually showing up for linkage. We could potentially start to look at prevalence within our emergency department, although that is not the goal of this project right at the moment. And I think there's some really interesting opportunities for creating more fully remote studies in terms of testing, follow-up, and linkage to care that I'd be happy to chat about. So I do think there's a lot of opportunities. Once we get this kind of foundation laid, I think there may be some really interesting work that can be done. I'd just like to thank the whole team. It's been quite a wild ride over the last 2 years, many ups, some downs, but I'm very excited to say that we're finally launching and we're finally getting done what we said we would do.